I'm actually very honored to be speaking to you today, and because I am a very new kid on the block when it comes to social pediatrics. As a result, I got here by wanting to explore the integration of public health and primary care in child health. And I somehow managed to get funded by CIHR and to convince all these people who are listed here to come along with me for the ride of exploring this issue, which was a ride for me. And they quickly taught me a lot of things. And so I'm extremely grateful to have so many amazing mentors and role models as a part of this project. The project that we undertook is a literature review of early childhood programs that are embedded, integrated, and that take a health equity perspective whose aim is to reduce health inequities. We did a realist literature review, which means that the analysis was very different from a traditional systematic literature review, and I'll go into a bit more detail on that shortly. And ultimately, the purpose of a realist review is to find evidence that supports explanatory theories of program success. And I found it took me quite a while to get my head around that sentence. So I'm going to try and explain it a little bit more in the next slide. So this is a depiction of context, mechanism, outcome relationships, which form the basis of the Realist Method. It looks for CMOs, or context, method, outcome, CMOs, that are supported by the evidence in the literature. So the approach could go like this. You first look at the activities, which I've highlighted in yellow, and the outcome, which I've highlighted in blue, and the relationship between the activities and the outcomes. Now, outcomes can be successes or failures. Unlike some other methods, we're very interested in what didn't work in the Realist Method. And this relationship is pretty basic. It's cause and effect. It's what we do all the time, what we're very familiar with, and what you might see in a logic model. We do certain activities, we expect certain outcomes. But where the Realist Method gets interesting is that then we look for evidence in the literature of why this happened by examining the mechanisms, which I showed in red. The mechanisms underlie the cause and effect relationship, and they're explanatory. They explain why things turned out the way they did. And then we consider the context in which all of this occurred, because certain activities and outcomes might work very differently in different contexts, given whether different mechanisms are fired or activated in that context. So for our review, our activities were social pediatric initiatives. We looked at clinical programs that were integrated in a multidisciplinary way, that were embedded in communities and whose goal was to reduce health inequities, among other goals, but that needed to be part of it. The method focuses on having specific outcomes. So the outcomes we chose were partnership working, reach of the social pediatric initiative to the target population, so accessing the initiative itself, the extent to which the initiative led to screening or early identification of medical and social issues, and finally referral to medical or social services of referral on from the social pediatrics initiative onto other medical or social initiatives. So that's the cause and effect we were looking for. And I just want to take a moment to explain a little bit more about mechanisms before I tell you the mechanisms that we found. So using the various realist analysis methods, which I won't go into, we identified mechanisms. Now, mechanisms are hidden. I really like the term that was used by an earlier speaker about making the invisible visible, because I think that's a lot of what the realist methodology is meant to do. Mechanisms are hidden and they link cause and effect. So like the apple falling from the tree. But that's a physical mechanism, the apple falling from the tree. Social mechanisms are a bit different. Social mechanisms are cognitive or emotional responses of the actor. So basically the mechanism is what turns on the mind, and it's a function of the situation, the context, that causes participants to take certain actions. Or another way to put it is what makes people want to achieve the outcome? What's the sort of secret sauce is what I think about it that makes people actually want to achieve the outcome of partnership working or screening patients or referring them on or what have you. So ultimately, a realist review will answer the question of what works for whom and under what circumstances. Realism is relatively new to our field. It's been around for a while, but it's only been applied to kind of health sciences more recently. And it takes a while for one to get into the different way of thinking, I've found. But at the same time, it's hardly rocket science, and I'll come back to this a few times, because what many realist results, including our own, do is that they really shine a light on what's likely already intuitive to many people in this room. So our quick summary of our method, so you have some context for interpreting our results. We searched the literature. We searched 5 databases with these 6 concepts here and all the terms that we could think of with librarians' help that would find the concept in the literature. So these were all combined, and we ended up with 13,000 abstracts, if you can believe that. My research assistants were a bit horrified, but we found we couldn't do a title review because we were looking for kind of such complex ideas. So we reviewed 13,000 abstracts, and we excluded those that were not available in English. We excluded those that were not clinical, for example, a school-based program that otherwise would have seemed very much like social pediatrics. We excluded policy initiatives, so there are a number that had a very social pediatrics-like policy that everybody should have access and reduce inequities and all those things, but they were sort of federal or regional policies, not actual implementation of programs. We excluded those that didn't have all of integration, embeddedness, and health equity. So in some cases you might have had one or more, but we insisted on having all 3. We excluded low and middle income countries, and importantly, we excluded articles that were descriptive only. We found a lot of descriptions of what people are doing, but we needed outcomes for the method. We needed actual sort of evaluation, methodologically based outcomes. So we actually ended up having to exclude a number of articles because they didn't describe either qualitative or quantitative outcomes, but it couldn't just be a description of like this is what we've been doing here. Right. So what we found, again, not exactly rocket science, for partnership working, we found that one of the mechanisms that allowed social pediatric initiatives to work was a willingness by all the partners to share status and power. As I said, this enabled the partnership working, and it was explicitly supported in a context where there was a commitment to shared values and goals to work in the best interests of the child. Some of the failures we found were social pediatrics partnerships where one of the partners, their fundamental value was not necessarily the best interest of the child. They were somehow in it for other reasons. We found that another mechanism was trust. Specifically, in this case, it was the trust of the families or children in their provider, either any social pediatric provider. And we found that working with vulnerable populations, that this trust was very often built not directly with the provider themselves, but through various bridging relationships, such as others in the community, trusted sources within the community. Sometimes the bridgers were individuals who had more of a peer-to-peer relationship with the vulnerable communities, who sort of bridged the relationship with the healthcare provider. In the fewer cases where trust was built more directly, having a non-judgmental approach to support the vulnerable families was the most critical factor in supporting them to access a social pediatric service. In terms of the actual delivery of the service, increasing providers' comfort and confidence in screening for social issues or referring to social services was a very important mechanism. The individuals had to feel comfortable doing what they were asked to do, and in many cases this required institutional support from, for example, a number of the papers were kind of done in resident clinics, in hospital setting resident clinics, and the residents required a lot of training and institutional support in order to feel comfortable and confident in making the more social diagnosis and referring to social services that were part of the clinic. So that was an important mechanism to get referrals made. And lastly, to get the vulnerable children and families to follow up on the referrals and to access social services and utilize what was available to them, many empowering strategies were found to be effective, fundamentally increasing the self-reliance of the vulnerable families. So families needed to feel that that they had some control, that they were able, that they wanted to improve their health, that they wanted to be involved in their health care. And in many cases, as you all know, the families that came initially to the programs were very disempowered, and they were not necessarily motivated. The word motivation did come up a few times. To follow up, but in our analysis we were thinking it wasn't really the motivation to follow up came more from a sense of self-reliance than something more external. So we had quite interesting discussions within our research team as we were doing the analysis to try and come up with the best description of the mechanism that we were able to find. And in this case, I think self-reliance worked better than motivation in this empowerment perspective. So academically, our results look a little bit like this. I'm not going to go through this, and as I said before, certainly this isn't rocket science to most of us in the room, but I think there are some valuable insights for many who might not understand as well what it is that social pediatrics is and what it might try to do. However, it's also important to realize that the Realist Method, as created, its purpose is to enable decision makers to reach a deeper understanding of the intervention. It provides policy and practice community a practical understanding of a complex social intervention by combining theory and a theoretical understanding of the intervention with empirical measured evidence. What it doesn't do is tell you what to do and how to do it, but it does help inform, it doesn't tell you what to do, but it does help inform how you might go about doing things in a way that could make them more successful. So in spite of the fact we started out with 13,000 articles, what I presented today was based on 7 programs that were described in about 18 articles. That met our inclusion criteria. Again, the most important one being the outcomes there. So I see part of my job here today as a call to all of you who are in the room to publish your social pediatric work in studies that report outcomes, whatever they might be, specifically outcomes and evaluations. Oops, wrong way. This way. And lastly, before I end, moving forward, having learned so much in this 2-year process of doing this review about a lot more than just public health primary care integration in child health, I hope to continue on this journey with related projects, hopefully doing some of those evaluations myself, and I'd be happy to chat with any and all of you about this work. That's my contact information.